Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Galad Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Maria Descartes, who will be presenting a lecture titled Genetics and Genomics Across the Lifespan. Dr. Descartes is a medical geneticist physician at Miami Cancer Institute, a part of Baptist Health South Florida. She is board certified in clinical genetics, medical biochemical genetics, and pediatrics. Dr. Descartes specializes in evaluating patients' family histories of cancer and providing cancer risk assessments for patients and their families during the diagnosis and surveillance stages. Dr. Descartes received her medical training at University of Puerto Rico School of Medicine in Rio Piedras, Puerto Rico. She completed her residency in pediatrics at San Juan City Hospital in Puerto Rico, followed by a genetics fellowship at Baylor College of Medicine in Houston, Texas. Prior to joining Miami Cancer Institute in 2021, Dr. Descartes was a professor of medical genetics in pediatrics and medical director of the genetics counseling from 2008 to 2015 for the University of Alabama at Birmingham. A prolific author, Dr. Descartes researches and has published in peer-reviewed publications, including the Journal of Pediatric Genetics, the Journal of Inherited Metabolic Diseases, Genetics in Medicine, and the American Journal of Medical Genetics. She has served as a reviewer for many publications, including the American Journal of Medical Genetics, the Cleft Palate Craniofacial Journal of Journals of Medicine and Pediatric Genetics, and the British Medical Journals, WebMD, Clinical Dermatology, among many other publications. Dr. Descartes is a member of several professional associations, including the American Medical Association and the American College of Medical Genetics. She is, of course, fluent in English and Spanish, and I would love for all of us to give a warm welcome to Dr. Maria Descartes. Dr. Descartes, thank you so much for accepting our invitation. The floor is yours. Go ahead and share your presentation.
Thank you, Dr. Hakim, for your introduction. So good afternoon to everybody. I'm going to share my screen with you guys. I hope that I have many years of doing genetics, and I'm still fascinated and in love with genetics and now what we consider genomic medicine. And that's want to share some with you, some of the most recent advances and developments in genetics and genomics. Genetics, as you all know, is the science of the genes and how traits are passed from one generation to another. That's basic genetics, that's Mendelian genetics. Genomics, on the other hand, has become now the fashion word because it's the branch of molecular biology in which we are concerned not only about the gene, but per se, the whole gene, but concerned about the structure, the function, the evolution, mapping of the genomes, interactions between the genes, and therefore, that's why we refer to what we do today, genomics. The genome, where genomics come from, is the complete set of genes that an organism possesses. In the human, or it can go back to the eukaryotic or even the virus, the genome. So in this next slide, I am just, many of us, remember, everything started, it started before Mendel in the 1860s. Then we came here to start, developing findings, chromosomes, DNA was identified, recombinant technology developed. In the 1990s, the Human Genome Project was initiated, and it is not until the early 2000s that we start applying genomics into the world of genetics and clinical genetics, thanks to the development of technologies that I'm going to mention at the course of this lecture. So, like I meant, the title says we are going to talk genomics from genetics to genomics through the lifespan, across the lifespan. And of course, we need to start the lifespan in this case with newborn screening, because we are going to be talking about Laura's lifespan, who is Laura is here. She's the new baby born to this couple. She has two older siblings, which we address today, Abby, Tess, and Laura, just recently born. So the newborn screening. Newborn screening, shortly after birth, a blood is taken from Laura's heel and sent to the state newborn lab, a screening laboratory, and her parents are told that this is a routine test. I'm sure their parents know that from the older child, and that no problems were found and no follow-up was needed. So this is the newborn screening as we know today. This is a more complicated newborn screening where we do basically genetic analysis for uric organic acids or amino acids to try to detect abnormalities in the metabolisms. But the screening is not only per se genetic, it's also, well, genetics is almost everything, but could be testing for thyroid, congenital hypothyroidism, or they can be testing for sickle cell anemia or the hemoglobinopathies. They could be testing also for congenital heart defects. So again, the newborn screening is just what we do during the newborn period. To qualify for a disease or a condition to enter in this group of disorders, the condition needs to be affect the child long-term. It's not just an acute thing that can disappear. It has to be long-term effects on the patient and also could affect the survival. And therefore, you know, you have to be very specific on what kind of test or diseases you are going to add. But the criteria for newborn screening testing for these disorders has to be important condition, meaning that can affect the life and the quality of life of the child, the lifespan and quality of life of the child. It can have an acceptable treatment available. If there's no treatment, there's no need for newborn screening. The facilities for diagnostic and treatment, they have to be available. There has to be difficulty in recognizing them. They're not going to just jump in our face or the pediatrician face. They're suitable for screening tests, meaning that, you know, the technology that is available is available and accessible. It can be given and provided for most of the newborn the nurseries and hospitals. The natural history is known. It cannot be any obscure disease. We need to know what is expected and the lifespan, etc., and complications. And probably one of the most important things is that this has to be cost-effective to diagnose and treat. So all these things are required for a condition to fit into the newborn screening criteria. So little Laura, all the tests that were done, she came back with, she passed with flying. No problems, everything turned good. They take Sarah to their house and do the regular newborn baby things. So the newborn screening, now that we're in the era of genomics, and I'm going to address, are we going to start doing genomic DNA sequencing and all these techniques that we have acquired and learned since the beginning of the around 2004? Well, you know, there is a lot of, and I'm going to mention later on again, there is a lot of questions that we as physicians and geneticists need to ask ourselves. This is an article from about 2011, this group from Callum Bell et al. They said, you know, when they did a newborn screening sequencing, DNA sequencing, and what they did with, they sequenced all the exomes in the child. And I will address exomes. There are whole exome sequencing and whole genome sequencing. And the exome are those things that they are make protein. So they're coding, the coding region of the gene. Well, this group identified an unexpected proportions back then in 2011 of literature that was that were annotated wrong, incorrectly, probably incomplete, and many common polymorphisms, making it kind of difficult to decipher if this was anything significant or not. The truth is that there are more than 2,000 traits that are recessive and that could be inherited. We could be at risk of having a child with any of these conditions. But again, what are we going to do with that information? Are we certain that specific changes are going to cause specific, the disease and the severity will be there? We do not know to this day if whatever we are going to find in a DNA in any person is indeed the cause of what this person will have. Is imagining a child just newborn, we don't know. We have no idea. So there's a lot of ethical and moral issues that we have to try to be very specific before we jump into that area. There are very many questions that we need to ask as physicians and geneticists. For example, can the DNA sequencing that we that identify the conditions at birth are accurate as later on? Of course they are, but what we cannot predict, what is there is there, the genetic material is there. What we cannot predict still to this day is when the patient will develop the disease. Will the patient develop the disease, the severe form or less severe? All these classifications that people get, we cannot make any prediction. So what are we going to do with that? Are we just going to putting the parents into panic mode? We have to be very careful. Again, is having a genome sequence from birth useful for the clinical care of the baby? Probably not, because we are not going to tackle many of these things until there are symptoms. Again, they might not develop symptoms ever. So why is the genome sequence revealing information that is on treatable diseases? We're going to tell the parents your baby is going to pass away and there is no treatment. And maybe it won't happen the way that we expect this to be. So what is the risk for the newborns, that the identification of specific variants such as predisposition for disease could lead to future discriminations, which we very well could. Job discrimination, health insurance discrimination. We don't know what the future is going to bring for them. So one more aspect. How might the use of genome sequencing affect public support for newborn screening programs? It might be that there are groups that want everything done and that there are groups that don't want anything done to these children. How feasible could it be for states to perform genome sequencing, which is the big question? How are they going to afford it? Because remember, economy is basic for this testing. And are there additional considerations to collect and store this newborn? Where are we going to store? Who's going to store them? So that, again, there is a lot of things that, the beauty of genome sequencing and what we're going to do for them, but we still don't know. So for now, we do not perform newborn screening in the quote unquote well baby for the heck of doing it. What we do know and what has been very beneficial, and in my experience, it has been beneficial for me when I have attended the NICU, the NICU, and seen children that are very fragile, might die anytime, and we don't have a diagnosis. So in that case, we do perform what we call the quick newborn screening test. And of course, in that case, it's a matter of not diagnosing because we know that the child probably will not make it. It's making a diagnosis so the parents know what is their future. What are they? This is going to happen again? Are they carriers? Is this a new mutation? These things that will benefit long term the parent of the child. That's what we're looking. And definitely we have identified that probably for that, what they call the quick newborn screening whole exome sequencing, is the diagnostic yield has been as high as 20%, which for many of you is not a lot, but for me it's a lot, especially when I can at least tell 2 out of 10 people what their child has and what was the cause of their demise. So again, a lot of things to take into consideration, but we are getting there, and this is coming no matter what. All this information to be offered to us and the public. So now we cover newborn screening, and now we also are going to talk about diagnosis. The newborn screening period is quick. Laura did good, and she's doing great. But what happened? Laura has a sibling, and Seth is 3 years old, and her brother. Laura is 3 now, and Seth is 5, and he has developmental delays, and he has been recently diagnosed with autism. Well, all children with autism, if you don't have a phenotype, a specific distinctive phenotype that can be diagnosed, you look like Down syndrome, which many of you know, or Williams syndrome, or something that is, distinctive to the eye of the geneticist and even, the pediatrician. Many of them have the same characteristics. You just cannot, they have one thing in common, developmental delay. So before the expansion of sequencing and the use of sequencing, even for doing chromosome analysis, the capture of genetic causes for these children, or if there was any genetic cause for explaining the autism, diagnosis of ASD or autistic spectrum disorder, it was very small. I can tell you that probably was 2 or 3%. Maybe some people more keen into this will say 5. But thanks to the development of the chromosome microarray, or what we usually call also array CGH, which it uses, molecular genomic hybridization and single nuclear polymorphisms, again, molecular biology. We have been able to do microdeletions, microduplications that were invisible to the chromosome analysis. So now we can combine molecular with chromosome analysis. And thanks to that technology, the diagnostic yield for individuals with autism spectrum disorder went from merely a few percentage to 8 to 21, which again, I could tell you that, tell somebody that what their child has is just an experience. We know that we are not going to do anything. We cannot revert what it is, but for some parents, they have an answer. And eventually we might be able to group them and treat them accordingly. But again, thanks to the molecular biology and my hybrid chromosome comparative genomic hybridization and SNPs, we combine again molecular biology with chromosome analysis, and this has meant a lot for a lot of patients with these unknown disorders, or nobody knows what they have until now. And it's becoming more and more rewarding performing, clinical medical genetics for even children and adults that have unknown cause of mental retardation or unknown disease. So now, at least we know that this is a possibility. This is the first thing that you do when you have a child in the clinic for developmental evaluation, unless you know right away what they have. Do you need to do a chromosomal CGH? Be sure that they are normal, right? So if that's normal, and then you are going to proceed to do some serious genomic testing. And this is when the next generation sequencing plays big time use for children, particularly with developmental delay and or dysmorphic features. So not going to bother you, but the sequencing, the next generation sequencing, it is a technique. They're more, probably they started with now and they have more than 20, 25 different ones, but it's, they prepare a library, they cluster the amplification, they sequence, they read. Of all these things, the most difficult and time consuming is this one, because they are going to have to analyze thousands of variants and determine if they're significant or not. And this requires a computer program plus the help of the clinician, the PhD, the investigator, and several other people that work, take an important role in this analysis. So when I was in the late 1990s, I remember looking into gene tests and I said, wow, we have 6,000 something genes that we can test now. Amazing. I was thankful. Well, let me just tell you what happened from the onset of the use of next generation sequencing, where you can, before it will tell to the old fashioned Sanger way, you will take days to do a sequencing, maybe of one gene. Now you can sequence the whole genome, the 3,000 billion base pairs in 24 hours. Can beat that, no? But again, by I told you, maybe by the end of 1900, then 1999, there were maybe 7,000, 12,000 genetic tests. By the beginning of 2015, there are 54,557 tests. It went up to 68,000 by the time of 2017, and right now they're close to 80,000. And these, and it's because again, the next generation sequencing got into play. They're still doing single genes, but now many of the newer generation physicians, geneticists are doing panels. They do a cardiomyopathy panel, arthropathy panel. They do a seizure panel. So, they throw whatever because they all have one thing in common. And that is the bulk of the testing panels, genetic panels. They still do single gene panels when that's what they're looking for, the family. But they also, you can look here that it's amazing how they also do mitochondrial testing that I'm not going to even mention here. But the human genome and whole exome test, it's taking a big chunk as well in the percentage of testing that are offered in many laboratories. So there you go. And I cannot tell you the immense gratification that you can get from just finding, giving again a diagnosis finally to a patient that for years you have followed and no clue. Because, if you start doing one test here and one test there, by the end of 3 single tests, you are paying for a whole genome or a whole exome sequencing. So again, it's not only fast, it's economic as well, long-term. So there we go. This is the next generation sequencing. We are reading the DNA. In 2001, the cost of whole genome sequencing, where you read coding and non-coding areas of the genome, was about $100,000 because of the technology and the use and everything. Now it is around, I would say, $5,000, which is considerably decreasing. The cost of living, it keeps going up for us, but anyway, it has gone down in price significantly. And I think that's another thing why people say, well, why get into we are never going to know horseback when we can just go ahead and do it right now and get it over with. Not that simple though. But again, we are doing gene panels, which, like I mentioned, is specific. They have a subject. We're doing whole exome sequencing when we are just doing coding sequences, just that code protein. And then the whole genome sequencing, where we are doing sequencing of both coding and not coding regions of the DNA, of the genome. The advantage of the whole exome sequencing, it tends to be more precise than the whole exome. But again, I think that both have their pros and cons. The diagnostic yield last time when I was doing more medical and pediatric and adult on diagnosed diseases, it was for the whole exome sequence at about 20-25% diagnostic yield, again, for unknown diseases. And then when you add the whole genome, it probably will go maybe to 30-28, depending on what lab you're reading about or referring to. So it's not much difference. It makes a little bit of difference in terms of the price, how much they're going to pay. But again, I think that by far for many of these undiagnosed disorders, most people go for whole exome. And if that is negative, then they throw the big guns with the whole genome. So because genetics is a diagnostic odyssey, and it's like even other clinical specialties too, but take again a child with developmental delay or seizures or regression or multiple problems. You try, you come to you make a differential diagnosis that doesn't work. You start throwing tests, one here, one there, panels there. By the time the child is getting worse or the adult is getting worse, you don't have a diagnosis. You don't know what they're going to. It is over and over again and becomes very tiring for the parents, depressing for the parents and yourself. You want to find an answer. It becomes like, it's an odyssey again. Never reaching a shore, not knowing where you're going. But again, in 2011, when the whole exome sequencing became available for everybody, this was the first known, maybe there were others, but this was the first condition that reached a New England Journal. This child that have a clinical presentation with intractable inflammatory bowel syndrome since the newborn period. They didn't know how to treat the baby. The child was 5-6 years of age, almost dying, and they decided to throw the whole exome, and they identified the cause and cure, because based on the mutation they found, they did a bone marrow transplant and the child improved. So how much more satisfying could this be? I mean, it could, I mean, you cannot beat that in my opinion, but anyway. But with the whole exome sequencing, remember, we are going to look through the whole genome, exome. So all the coding regions of your genes, the coding genes. So the doctor, the physicians and PhDs are going to go through genes that, are disease causing, and what if they identify that you are a carrier for an adult onset or potentially lethal condition. Those are what we call in genetics incidental findings, because they are clinically significant. They're secondary because not the reason why you went to see genetics, but then they became a big debate. Do they need to know or do they not need to know? Believe it or not, you have to, not believe it, you have to take permission to do a whole exome sequencing to the patient, and you have to ask the patient if he or she, or the parent, in this case, and if it's a child, wants to know about the secondary findings or incidental findings, which the American College of Medical Genetics decided that it was going to be this group of disorders. Many of them, as you can see, are related to adult onset colon cancer. I apologize. Breast and ovarian cancer, polyposis, cholesterolemia is not a cancer, but it's adult onset. Many of them, cardiomyopathies, long QT syndrome, TS or tuberous sclerosis, familial thoracic aneurysms and dissection, Liefeld-Menis cancer syndrome. Again, conditions that many of them, as you can see, are indeed associated to malignancy, but others are not. And it can change it could benefit for you to know if you have long QT syndrome. It can benefit for you to start screening for cancer sooner than later. So again, some people do prefer not to know. And that's their right. But counseling is very important, and they need to give consent. And the consent is irreversible. If they don't want to know, they will never know. The laboratory will never give them the results. So one thing to consider, and be very specific to the patients up front. This is it, yes or nay, and this is no, we are not coming back. Who decided that? It was decided that way, but it is the way it is. So now we are going to talk about preconception screening. What is the role of genomics in preconception screening? I apologize. So Laura is married, and she and her husband want to start a family. And they are both, this is back in the time when I did prenatal counseling. Are you from Northern European ancestry? You have a 1 in 20 risk for being a carrier for cystic fibrosis. Oh yeah, I want to be tested. So we want to, now it's not that simple. So it happens that both Laura and her husband are carriers for cystic fibrosis, are carriers for the disease what is autosomal recessive. So if I'm a carrier, my partner is a carrier, there is a 25% chance that my child will be affected. Every child we have together could be affected with cystic fibrosis, which is very wide spectrum is a wide clinical spectrum, but in the severe neonatal form is pretty bad, and still to this day there is not a cure. And again, it can have a very bad outcome. So this is just to show you, this is the gene, and the protein is a chloride channel, and this was in the 90s or late 80s. And but now we know that not only people from Northern European ancestry are at risk, but there are other groups that are at risk for carriers because whatever, the isolation, Finnish, Amish, Ashkenazi Jewish community population, African, Asian, Mediterranean are very predominant hemoglobinopathies. Panethnic, cystic fibrosis is panethnic. It's not only limited Northern European. They also spinomuscular atrophy, also panethnic, and then the Jewish community do have a group of conditions that are listed there. But they're a usually very active community. that are quite very well informed. So with that, we offer to these people this, this testing. Now, is this fair to offer only them this testing? Well, apparently it's not, because humans, we are much more diversified, not only in terms of diversity that we claim to be very diverse and tolerant, but also that people mingle. People are not isolated anymore. They marry, there is not, again, they're not isolated, and they're open to other marriages, not just restricted to whatever the community or the society wants them to do. So for that reason, people decided that genomic screening carrier, it's important to realize that thanks to, again, the next generation sequencing and identifying that we all carry a genomic burden, carrier burden for recessive disorders. It doesn't matter where we come from, where we are from. There is from 2 to 7 recessive genes that we all are at risk of carrying. So if I do that, my partner has the same average number and so on. So taking that into consideration, that we know that we all carry genes, it could range again from 0 to 7, they say, but it could be much higher too. Again, there are some communities, Finnish, Amish, that do have a higher genomic carrier screening or genetic burden, if you want to use that term. I believe that word burden will be eliminated soon because of somebody's not going to like it, but it is what it is. It's a burden to be a carrier for something. And then we are going to do now, we have to consider that I want to mention, and I know what I want to tell you. Now you can go to Natera. I have nothing to do with that. This is something I tell anybody that asks me. Natera is a company, and you can be tested for 480 recessive conditions to see if you're a carrier for which one. So you can go with your partner and say, I want to see what I am carrier for, and you can pick and choose what conditions you want to be tested, or have the whole panel, which is right now 480 autosomal recessive and X-linked some of them conditions. So we're getting fancy and fancier. Okay, so they're pregnant, they're carriers, both of them, like I said, but they decided that they wanted to do prenatal testing. And that is genetics that is done before the baby's born. Now, Laura are both carriers, and they decide to go ahead and do the amnio again. This is more for the time when I was, doing prenatal counseling, but still some people do to this day decide to do amniocentesis around 16 weeks of gestation, and the baby is found to be a carrier for cystic fibrosis. So great, good news. Not affected, a carrier like mom and dad. But there are options. There are options that can be offered for conditions that are, serious, lethal conditions. CF could be too, but again, we can offer amniocentesis, which we also do around for prenatal diagnosis. We can do it around 16 weeks of gestation. We can do CBS, chorionic villus sampling, around 14. More invasive, a little bit higher risk for miscarriage, but I think that in the right hands, with the right experience, it's really not that high. I think that many of the pregnancies in the first trimester is very 25% of the pregnancies are lost in the first trimester without doing any surgical intervention or anything. So maybe some of this is that background. And again, you can also do pre-implantation genetics or diagnosis, in which what you do is you fertilize in vitro, egg and sperm, fertilize, and when the zygote forms, you remove one cell and you study that cell for the mutation of interest. You cannot do so far whole genome in that cell, but you can going to look for the particular disease that the family is interested in knowing. For this, the insurance do not pay. You have to pay. You have to pay for the IVF, and you have to pay the laboratory who performs the genetic diagnosis overnight. Have to be shipped overnight and taken care of quick so that you can have a diagnosis and make a decision based on what they find. What they do, they have several embryos, and when they will implant the embryo, that of course is not affected in the model. Okay. And now we are going to next generation prenatal screening, but this prenatal screening is done in maternal blood. This is the last thing, is the part that we call non-invasive prenatal cleaning, where they do and check if the mother, they draw the blood and they look for fetal cells, and they test the fetal cells to see if the fetus is a carrier for the common trisomies, Down syndrome, trisomy 21, trisomy 18, or trisomy 13, which are good, very reliable. There is an error about 98% reliable. When it's positive, that is, if it's positive, it's most likely that's what the baby will have. And that again, this is done again in maternal plasma. They do DNA sequencing of the fetal cells. You can also do genomic prenatal diagnosis, but God knows, if you have problems determining what it is when the baby is born, imagine the unborn child. I mean, the ethical considerations here are innumerable. So, but it has been done. This is from a group in China, and they, again, proceeded and were successful in and doing some fetal whole exome genome-wide association and profile. So it's possible, but again, so we are getting of age, and then Laura is now 45, and her sister, Abby, 49, has been diagnosed with breast cancer, and she's concerned about her risk. So this is the family tree that probably should have been earlier, but look at this. This is her sister, Abby. She has breast cancer, but then she has a first cousin with breast cancer on the paternal line, and then a paternal uncle and a paternal grandmother with breast cancer. And then there is ovarian cancer, and 3 generations here affected. Wait, and of course, 49 is relatively young, still, for breast cancer. So she gets tested, and she came back positive for the BRCA1 mutation. This is autosomal dominant, so most likely, but look, here is also this guy who is prostate and this one who is long, but again, what any good geneticist will say, we have to be devil advocates. Most likely it's the paternal. We can start with the paternal line, but we are not guaranteed until we prove it, right? Prove. So let's say we know, and again, she is inherited this most likely from her father. And so her siblings have 50% chance each to be also carriers for the same mutation, because this follows a dominant pattern of inheritance. But thanks of the knowledge that we have now about BRCA1 and 2 and other cancer genes, familial cancer genes, that put you at a risk. Notice it's not a death sentence, put you at a risk for for cancer, whatever cancer we are dealing with. So for that reason, again, by the late early 2000, then guidelines start to develop and identify, and recommendations based on guidelines are given and provided. And this is the difference when they before and after, when they follow the patients only with surveillance for ovarian cancer, that we know that the surveillance, the screen test is very poor. And compared to those that salpingo-oophorectomy was to be considered after childbearing age, 35, 40, 45, depending when they're done, and look at the difference in survival between those that had the risk reduced in salpingo-oophorectomy and those that did not. I mean, significant. We cannot cure it, but we can definitely decrease the incidence of complications. Cancer genomes, of course, they do genomics in cancer genomes, because that is going to make very specific changes. Not all cancers are the same. Every cancer has their own genome. And that's what they're trying to do. They're trying to tackle those that have something in common, so they can a specific of that particular cancer and attack and treat that way. And in that case, we are doing that currently. I mean, they're doing, for example, for those that have HER2 positive, they're giving them medication that inhibits the excessive expression of the HER2 gene, and And the opposite for this melanoma, they try to block the same, to block this gene, BRAF, with the by giving them medication that makes it stop and not be overworking, overfunctioning, and therefore feeding the cancer cells to continue to proliferate. So again, we're getting, more specific. Before we inundated patients with chemo, and God forbid, probably many of them were more dangerous than not. But again, now we're going to try to tackle the problem down to the root. So I'm going to briefly mention this. This is kind of catastrophic, but all these pre-diagnosis and diagnosis, everything that we do in medicine could have a tail, and we need to be aware of the consequences. We cannot take this testing lightly. We say, oh, and then you see the test, oh, well, I don't know what to do. What am I going to do with this information? There is this patient, 55-year-old female dialysis, that she was identified as a carrier for autosomal dominant polycystic kidney disease. She has 4 sons who underwent screening and were identified, all of them, as carriers. One of her sons was 32 and the father of a 6-year-old when he developed symptoms. He committed suicide. Another son, 30, divorced his wife, sold his house, and became their home, and divorced their wife so he would not be a burden for the family. He later died, and then he had no problems until he was 54. A third son, 25, left his fiancée for the same reason, and he later died from another cause without ever having developed symptoms. The fourth son, 21, also a carrier for the same disease, of course. He quit school, he took a good paying job for life, to live life, and to the fullest, he never married. At the time of the article, he was 42 and he had never experienced one symptom. So the family, this is an example of we have to be careful, and we have to be very conscientious about what we are telling the patients and why. If you are not certain of what the psychological, what's going on, the patient needs to be evaluated, and this needs to be taken seriously, because it can make decisions that are devastating for the patient. It is not what life is best worth living. Who's going to decide that? So again, important, I bring that up because I'm talking about all these, but I'm not talking about the people we are doing the testing. What does it mean to them and their families? We have to be very careful. So we went to pre-symptomatic testing. I'm going to tell you Laura was negative. And then Laura is now of age. And she's 60. And she is in good health, and her husband, they want to have her about, having genomic testing done. And they're going to do direct to consumer testing, like many of us do. And then I have done it, 23andMe, and no, I didn't do the ancestry, DNA ancestry, and explore the possibilities through the internet. Good. So she starts looking for possibilities. And let me just give you heads of what this direct to consumer genetic tools testing offer. What they offer is SNP, single nucleotide polymorphism association. And this is an example here. I'm not going to go, but you have allele present, 300 of people that have psoriasis, 100 in control, allele 2 not present in 700 of the patients that do not have psoriasis versus control. And they make an estimated calculation based if the presence or the absence of the SNP is going to be associated with the disease. That's basically what they do. But these are some of the consumers, Navigenics, 23andMe, and Decode, and Ancestry DNA. Again, what they do is what I just told you. They look at SNPs, and they give you a risk. And that risk is a risk. That's it. For diabetes, well, if you're obese, and even if you're obese and you have a bad diet, you don't exercise and you smoke and you drink, chances are that, yeah, you will develop no matter what, diabetes, regardless. So it's interesting for me. I'm just going to give you, people come to me my colleagues too, with a genetic test from 23andMe, and I tell them, no, this is not diagnostic. And they believe them and not us, because they are already, somebody answered what they wanted to hear, and that's it. No matter who they talk to, They believe that before they believe the geneticists. So again, but I always find interesting, again, this is just a risk. One thing that I do want to show you is that if you put these different, the 5 different direct to consumer, the most important thing here is, I believe, is that if you see, they do not agree. They have 50% agreement, even examining a patient with the same quote unquote SNPs. So there is no consistency, there is no agreement. There is no like a science that we learn. You have to be able to replicate or duplicate the experiment, not here. So, American College of Medical Genetics is not telling not to go there. They have some basis on fundamental use for pharmacogenetics and all this stuff. But again, you have to be cautious. They are also notorious. They don't counsel the patient. They don't do anything with them. They throw the test, and then the community doctor or whatever needs to take care of what they cost. So now, after the genome project that, was revolutionized all of us, genetics and medicine, particularly, but genetics more so, we are finding SNPs. Before there were like, let me see how many were. In 2011, there were in this whole genome-wide association, there were 1,319 SNPs that were associated to specific traits. Now, on February 22nd, of February of this year, there have been 345,744 variant trait associations identified so far. And many, many, many of them in non-coding regions. So we know that the coding regions, if you have a variation, is probably going to affect the function of the gene, not necessarily, but usually. But in the non-coding regions, most of them, we understand that these non-coding SNPs are affecting and probably modifying the expression of nearby genes. So again, fascinating for people say, I'm going to have my polygenic SNP score done. We are not even closer there, probably in the next 5 or 10 years. That takes a long time to develop. But again, look, there have been more than 309 non-coding variants for 252 genes. So I think that's another way to figure and see genomics coming down the corner to facilitate diagnosis and treatment, hopefully. And again, many of these SNPs are mostly in polygenic conditions, like example, cancer is polygenic, multifactorial, cardiovascular disease, diabetes, obesity. All of these are, again, common trait diseases that are polygenic and multifactorial. And this is where we're finding many of these SNPs. So we are not going to tell you that genetics, they don't know it all. We have to understand that genetics, if you see that in the first year of life, before we go and start eating junk food, the genetic variability is quite comparable. Doesn't increase the risk of presenting. But look, as we get more older and exposed to environmental factors, and again, here is when there is definitely an increased risk for the disease. Could be also that we are getting old, I don't know, but also definitely liability is very stable in the beginning, and then here start peaking and peaking and peaking throughout our life. And again, here comes lack of exercise, smoking, drinking, alcohol, drugs, exposure, blah. Everything that we tell the patients that we probably do or do not do, that the doctors tell us to do, and we don't do it. So longevity, another one, influence genetics. Of course, 20 to 30% lifespan length is determined by genetics. But again, there you go. You might not get to do all if you smoke or do something that, I don't know, whatever puts you at risk to have get older and obese or something that was going to shorten your lifespan. So again, yeah, you can get along. Some people have good genes for very longevity. I also say quality. What kind of old person you want to be? You want to be not moving, or you want to be moving and active and giving your opinion. So we have to decide. So all this information, data, where are we going to store? That's another problem for another person. We don't know. This is going to be out there in the web, in the cloud. Are we carrying this in the personal devices? The thing is that if you carry your genome information, that you can provide that to your doctor, so they can provide you what they used to call personalized medicine, which now is not considered appropriate because it limits, like it seems like it's just for a few people, and now they call precision medicine because it involves molecular profiling and the use of therapies to target a specific disease traits. So now we call it precision medicine. So if you are going to carry your, again, your profile, are you going to carry it? Are we going to have a bank? Are you going to have a password? Where is it going to be? If it's in the data, this is in the cloud. Who is, are we exposed to something? Probably. Somebody will figure a way to hack into all that. But again, so, that's the goal, that we do personalized or precision medicine. So we can all treat your cardiovascular disease different than your neighbor next door because you have different SNPs. Well, I just wanted to, let me see. Maybe, no. Well, I just wanted to show you that we started, Mendel, Mr. The cat in the hat and just very simple sentences. And then we did the human genome, and we found all these words. And in the beginning, they said, oh, this is just like, 99% of the genome is trash. Well, it happens that now, instead of having 22,000 genes, we have 44,000 and many more that are non-coding messenger RNA. And it has become that what we thought it was going to be simple to understand is become like reading Ulysses. And not only that, within Ulysses, we are like in the mountain of Babel trying to determine nuances. Are my nuances going to be different from the people that live in another country? Or what are the people from my country that stay there? How different are we going to behave in the term of medical terms? So it's going to become, the never-ending story, but it's becoming more and more fascinating, in my view. So one last thing is that I want to mention. No. No, again, we go back to the ethical. I don't want to bother you with this, but this is very extremely important. The tools of genomics are resolving. No, we are not even close to getting 50%, but are resolving the etiology diseases of some previously undiagnosed conditions. I have witnessed it. I have the glory, the satisfaction of going through that, telling someone what you have. We have identified cancer driver variants. We are impacting understanding the disease pathophysiology. We are developing techniques for genes dissection. Like, for example, CRISPR. We can manipulate the gene and alter the mutation. We have done that for sickle cell, and they have done that for leukemia using CRISPR-Cas9. Great, there is a great step. Much of the future of genomic medicine relies more on the phenotype association and knowledge of the genes and the proteins those genes code. So we are trying to see what the heck do they do really, and what is the difference. As any one variant may not act alone, we must consider epistasis, and that's exactly what it means. One variant, and what I tell patients all the time, this is one gene. We don't know how that gene interacts with what other gene, because we don't know that other gene. We don't know anything, how the interaction works. And the gene modifying within the genome. So we must remember that genomics cannot explain all disease risks, that we need to consider and continue doing lifestyle choices. Environmental exposure is important. Microbiome is important. Microbiome is us, and not only us, but the microorganisms that are within us and the environment. What is my interaction with my microbiome, and even cultural upbringing need to be merged with genetics to create a full view of the diversity of the human biology, which is, these are fascinating times for everybody to embrace molecular biology and the wonders that do to medicine. That's it. I'm done. Enough for you.
It is not necessarily enough. We can have you talk on this for hours. What a fascinating lecture. Thank you so very much, Dr. Descartes. We have a couple of questions before we let you go because we're on top of the hour. But I wanted just to quote you on some of the stuff that you left us with, which is truly some of the pearls that we will be taking, especially from a specialist in genetics. You did mention we do not treat the great majority of the conditions. Oftentimes, this is for the benefit of the parents. What a true statement is this. I mean, for years, we have been speculating about these conditions, so we had no idea what they were. No idea what they were, and all of a sudden, we have a revelation. No wonder you're so excited about the new technologies. No wonder you are thrilled to actually give a little peace of mind to the family in order for them to plan ahead and make certain that the future generations are not necessarily suffering, but if they are carriers, to be cognizant of what is to come. So some of the things that you mentioned, for instance, the life-threatening, life-altering type of knowledge that if you are to inquisitively try to find the condition, you will probably find it. I mean, it is a gamut, an incredible amount of variabilities in our chromosomes and in our DNAs that you will probably find something.
Oh, absolutely, yeah.
Yes, and it alters completely the life of that person that is receiving the information, and especially when there is, in your case as a physician, as a geneticist, that you get a patient that is diagnosed, let's say, as straightforward as breast cancer, and all of a sudden you're called in to actually counsel the woman and the man in that family. I mean, how altering that would be. If you recall, many years ago, some young woman had to actually undergo bilateral mastectomy simply because her mom, her aunt, and her grandmother suffer from that condition. It is absolutely brilliant. One thing I wanted to actually ask you, and it had to do with also the slide that you talked about in identifying through the RACGH for babies or kids rather that are autistic. There has always been this commotion about IBF and autism. How do you set that in your mind? Is there a correlation between IVF?
No, there is a correlation definitely for more. They have noted, and they have not become given like this is the risk that you have. We mentioned to the patient there is a risk for conditions that are like methylation abnormalities. For example, Prader-Willi, Angelman, BHIWebinars, they do have methylation anomalies that these individuals could be. They have noted that some of these patients have a higher risk than expected when these are rare disorders. But to this point, I don't think that they have become like a warning. We mentioned that to the patients. Many times the patients, when they do for genetic counseling, resort to this IVF is because they are hoping that the baby do not have some lethal disorder. And yes, may be concerned about it, but they don't turn back and don't do it. That's what I'm trying to say. But yeah, there have been some, instances definitely that there could be an increased risk for, again, people, conditions that are abnormalities in the methylation pattern of the genes, what they call, those are inherited from mom and dad. Again, these are specific syndromes, and definitely with IVF.
Interesting. Dr. Suarez is asking, what do you think of the future of gene testing for new generation? Should a couple decide at pregnancy or before pregnancy?
That's when I say that will be very independent of the person and the person's ability to pay. That's what I think it's going to end up. Even if the geneticist, if I say, I will not do it, I'm not going to be able to do the test because I think this test is not going to accomplish anything good, probably bad long term, and we can't do anything about it. So there is going to be someone that will give the test to the patient. So given the society we live and the health, I don't see that this will happen available for any of us or all of us anytime soon because of the price. And the health insurance will not cover it.
Yeah.
So again, ideally in utopia, but again, with that utopia comes all these other considerations. Who is going to counsel these people? Are we sure that they're emotionally prepared to get the bear there? What are they going to do with information? It's a lot of things we don't know. Do we want to be again? Decide what the child is going to look like? Are we going to base genetic testing based on the looks that we want our baby to have or the traits? I don't really want to leave that point because I think that we are going to be dealing with the devil then.
I agree.
Not that I believe in the devil, but bad things are going to happen.
In a negative sense, yes.
Yes.
As these tests become more affordable, do you think it would be a norm for teens to test their genes before diagnosing certain conditions, becoming similar to a regular blood test?
Well, I think that I don't think I understand very well. I do understand, but let me see if I'm wording.
As they become cheaper, do you think, in your mind, do you think when it becomes readily available, teens will start using this testing?
I think that some people will. I always say, don't fix it if it's not broken. That's my motto and my motto in life. But some people want to know everything.
Yeah.
And then they can live with that. I can live with that. I can live with that. Other people can't. It will depend a lot on the person.
Yeah, it will freak me out if I may.
Yeah.
To find out I have.
I don't know. I mean, then I'm going to have it. I'm not going to have it. I mean, what the heck? I can't do anything about it, though. I don't know.
That's exactly right.
They're all different.
I would have done something if someone would have told me I was going to be bald. I would have definitely done.
I read somewhere that they have found a bald gene in.
I know. I'm so excited about that. So let's see what happens. Hopefully, you guys can get us some pills there.
Yeah.
Is 23andMe or services like that reliable? I think you already answered this question before.
Well, they are reliable. They have to be taken. They're not definitive. They're just associations. They're risks. One thing that you need to know: these people do not do gene sequencing. They're just doing SNPs. So if they tell you that you have this SNP in this this gene that causes the condition, this is not definitive. They are not doing sequencing. So again, they should be more careful about when they give counseling to the patients, and they do not. So again, they come to the public, the geneticists in the outside, and then burden, not burden, but overwhelmed. And then, do they believe you? Sometimes I wonder. But
right.
But again, in terms of sequencing, no, they're not sequencing. They're not telling you. They're not reading the whole thing. If you're a carrier or not, they're giving you a SNP. That's it.
A snapshot of what probably is. In Guatemala, the newborns are tested with tamizaje, genetic testing. I think that's the aneuploid DNA for additional or deletion of chromosomes. I believe that's what it is. What do you think about this? Is it accurate?
What is the name of the test?
Tamizaje. Tamizaje is if you recall the old days, they used to use this test for a deletion or addition of pairs in the chromosome to determine, a triad or whatever. So they're wondering if it is accurate. I honestly,
I'm going to be candid, and I'm going to tell you that I have never used it or heard of it actually. So
I don't think we use it here, Marceli. It is something that it was used in the past, especially in the old European type of again, it is for aneuploid conditions.
Okay, I'm going to look into it now. Thank you.
Yeah, sure. So that was this is fascinating. Dr. Suarez mentions, and then the last thing, I do not understand what Enrique is trying to ask. What are the variants? Why? You know what? I cannot understand this particular question. I apologize, Enrique. It's not very clear. It is the top of the hour, Doctor. You have been very, very generous with your time. And for that reason, on behalf of the entire team at Baptist Health International, I'd like to thank you once again for this incredible presentation. I hope we can hear more of the future of genetics in the near future.
Yeah. I hope that from this, I always hope that someone will get so enthusiastic that we like to join and do genetics.
And that is something that is dear to many, many people's heart, and especially the young people that are witnessing or are participating today. Thank you for your interest. And if you if you feel that you should be in this particular field, please let us know. I would love to join you in conversation with our good Dr. Descartes. And
Yeah.
if you have any additional questions in regards to what we do at MCI in regards to genetics and genomics and genetic sequencing and obviously genetic therapy, gene therapy rather, please feel free to email us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. I would love to respond to all of those questions through Dr. Descartes. We look forward to seeing you all in our next quarterly lecture series, which is scheduled for Wednesday, November 30th, 2022. Thank you once again. Have a wonderful, wonderful semester to all of you in the different universities. Thank you again for joining us. Have a wonderful afternoon. Thank you, Dr.
Bye-bye.
Descartes.
Nice. Thank you for everything. Bye-bye.
My pleasure.